And first of all, let me wish you a happy Merry Christmas. All of you, it's a Sunday. You should be able to enjoy after 10 p.m. We'll try to finish by 9:30 so that you can spend time with your family today. As I said a few minutes back, the topic of discussion is uh, all right. The approach of cardiomyopathy is based on certain very important criteria. The first and foremost important criteria is very high index of suspicion in a patient who has come with a breathlessness. And you look at his history, the history will point more towards a cardiac illness rather than a respiratory. What does it mean by? The important part of the history is if you ask them whether they are more breathless on lying down position or in sitting position. And majority of people will come up. When they sit down, they feel better. And when they're lying down, they'll feel worst. They'll have all the features of maybe a left-sided or right-sided congestive cardiac failures. ECG may be non-diagnostic in many of these cases, but XHS will definitely helpful in telling about cardiomyopathy, cardiomegaly, as well as chest congestion. If I have to comprise all these things in one go, any patient presenting with breathlessness, we should evaluate with echocardiography, which is diagnostic both in terms of a left-sided lesion or right-sided lesion. It could be a left-sided illness or it could be a right-sided illness. If it's left-sided, which is left-sided cardiomyopathy. If it's a right-sided, it could be right-sided cardiomyopathy or the effect of left side or a right-sided condition per se, like COPD leading to increased PA pressures. Next question comes, what all we look for? We look for systolic LV dysfunction, whether it's coronary versus non-coronary. We look for a diastolic function, especially I said hypertension, diabetes, mellitus, aging, hypothyroidism, sleep apnea syndrome, and many more conditions. We can have a left-sided lung conditions producing all these kind of abnormalities. We could have a valvular heart disease. We could have a pericardial disease. We could have a very interesting phenomenon, arrhythmogenic right ventricular dysplasia or a cardiomyopathy. We'll be coming to them one by one. What we need to emphasize is we have to classify them in a primary cardiomyopathies, means where the cause of affectment of muscles is unknown or idiopathic, and a secondary cardiomyopathy where the cause is present. Like if I go back to my previous slide, valvular heart disease, pericardial diseases, systolic dysfunction, especially coronary. Then we know diastolic heart failure, hypertension, diabetes, and aging, and these are like leading to heart failure with preserved ejection fraction. They'll present like cardiomyopathies. So we have to distinguish between primary versus secondary. And in primary cardiomyopathies, the most important part is the cause is unknown virtually. Involvement of muscle is present, cause is unknown, and very high incidence of mortality versus morbidity. I request everybody please silent their mic. There's so many people who are talking in the back noise. Please request to silent your mic. Dr. Pranjal Gupta, your mic is on. So in this subset of population, the mortality and morbidity is high. I'm not saying that it's not there in other cases. Since a very common example is suppose you have a dilated cardiomyopathy with a normal coronaries. If you had abnormal coronaries, you can imagine like these people, we can certainly do an intervention, open up their vessels, the heart will resolve. But the person who has got an abnormal coronary, what do you do about? Only thing is either you go for medications, if they are successful, is okay, or else you go for a CRT device. Is that is okay, that's fine. Or else we go finally for what? Cardiac transplantation. So that's how these primary cardiomyopathies, they are more dangerous. Similarly, example is postpartum cardiomyopathies. Causes are known. And majority of these, the 50% they resolve and rest of them they do not resolve at all. And even if they resolve in the second pregnancy, there were very high chances of developing a cardiomyopathy again. So most important thing is look for a cause. If the cause is not there, there becomes a primary or idiopathic cause of a cardiomyopathy. Then in primary cardiomyopathies, we have dilated, and majority of time is not ischemic, which is non-ischemic cardiomyopathies. Then hypertrophic, it could be obstructive versus non-obstructive, and restrictive cardiomyopathy. I'll have to remove this word of ischemic because ischemic is not the variety of a dilated cardiomyopathy. Then in looking at all these kind of a thing, we can classify them further as per literature. The cardiomyopathy is a disease of heart muscle that causes the heart muscles to become enlarged, thick or rigid. It can have many causes, signs, symptoms, but some people never have symptoms at all. As cardiomyopathy progresses, the heart becomes weaker and weaker. It is less able to pump blood through the body, maintains difficult to maintain a normal electrical rhythm, and leading to heart failure with irregular beats or arrhythmias. We talked about dilated, we talked about hypertrophic, we talked about restrictive cardiomyopathy. There are many more of them, like left ventricular non-compassion is a variety of DCM. Then ARVC is an interesting phenomena, which we'll discuss in a couple of minutes. So here's a pictorial diagram of a normal subject versus our dilated LV. If you look at this dilated LV, look at the concentrate on the thickness of these muscles, and which we calculate as 12 millimeters up to 12 millimeters. They thin out over a period of time. And on top of that, they becomes dilated and the pump get affected. Normal anatomy, we have a four-chamber dilatation. We may have hypertension or we may not have hypertrophy. Valves are normal and annuli are dilated. What do you mean by? You can have a dilatation of both LV as well as RV. Then when the LV gets stretched up, what happens to annulus? It also gets stretched up. So, but the valves per se, they'll be normal. If you look at the thickness of the valves or a calcification of all, you may find a minimal thickening, minimal calcification, not contributing to development of dilated cardiomyopathy. Histopathology, fibrosis with myocyte hypertrophies, and role of echocardiography comes in diagnosis. The most important thing is how severe the disease is and what is the disease. When we look at a disease, then we talk of prognosis, hemodynamic information, helps in guiding the management, follow-up evaluation, and excluding other cardiac lesions. And then we come to know whether the cause of a dilated cardiomyopathy is manageable or primary or secondary. It's a variable clinical presentation after COVID-19. They may be asymptomatic, but yet dilated. They may be recovering from a viral myocarditis, heart failure, dyspnea on exertion, or orthopnea is a majority of time is the most common presentation in the form of patient presenting with LVF. And if they develop a right heart failure, it's an ominous sign, because ominous sign is why all of us can understand right heart is a pumping heart or a heart which helps you in flowing the blood into the LV. If the right heart fails, what exactly that means by the filling the heart goes down dramatically. Causes, as I said, idiopathic in primary, and either this could be a toxic or metabolic or infectious. Common other things is alcohol, postpartum, infection, hypertension, diabetes. Now, at this point, many of my students or many of the people sitting over how a hypertension or diabetes can give rise to a cardiomyopathy. Well, the most important part is if somebody is hypertensive, what happened to muscles? The muscles, they'll get hypertrophied. And that's why I said hypertension could be a positive factor or plus hypertrophy could be present or absent. If they are persistently at a high pressure over a period of time, what exactly happens? The muscles, the chambers, they start dilating. That is hypertensive heart disease. On the other hand, diabetes mellitus can give rise to microvascular disease, where the corneas may be normal, but the muscle starts getting affected with a microvascular disease, and that leads to a dilated cardiomyopathy in diabetes populations. If you are able to find a cause, believe my word, that's the most important thing of any dilated cardiomyopathy. Before I go further, we saw many patients during our recent COVID-19 patient presenting with dilated cardiomyopathy. Secondly, due to viral infections. Toxic or metabolics, they do present with dilated heart and poor LV systolic function. So in turn, what will happen? If I'll have go back to my previous slide and explain you in a one simple fashion, my heart starts dilating and it dilates not in the apical segment, not in the basal segment, it dilates in the mid segments. It leads to annular dilatation because of a stretching effect. So what happens? LV function goes down. One, LV is dilated. LV wall thickness is reduced, appears reduced in size, thickness. Annular dilatation leading to significant mitral regurgitations. And this dilatation in the mid segment will lead to reduction in this E point septal separation will start increasing in M mode itself. And when these kind of phenomena are present, request everybody, please silent your mic. Please silent your mic. That's my humble request. Many people, they're still having a mic which is still open. So what will happen? You have a global LV hypokinesia, cardiac enlargement, impaired cardiac function, mitral regurgitation, and finally leading to involvement of a right ventricle. And if you happen to find a hypokinesia versus local wall thickening abnormalities in presence of a dilated cardiomyopathy, this is a very good sign. Because what does it mean by some segments are contracting, some segments they are not contracting. If you happen to find some segments which are not contracting, it means what? We are dealing with ischemic dilated cardiomyopathy. And with intervention, we can really relieve them of their illness to a large extent. Let's see what are the echo features. LV wall thickness is normal. I said initially is reduced in the sense normal LV wall thickness is 6 to 12 millimeters. So it becomes approximately 6 to 8 millimeters, not up to 12 millimeters. You can have a 4-chamber dilatation. Initially, you can have dilated LVLA. Subsequently, you can have a dilated RVRA also. Dilatation is usually the short axis, the other long axis. I said mid-segment dilatation. Reduce LV systolic function. It could be anything. I cannot say about 40%. Reduce fractional shortening. Increase E point septal saturation. Gradual systolic closure of aortic valve in M mode. Why it happens? Normally, a closure is like a box. And when the closure is like a box, what exactly happens is this closure, which is happening in a box forms, when a lot of blood is going for mitral regurgitation, it will start closing down in the early systole itself. Then, based on this, we can have a diastolic function, which could be abnormal or restrictive filling pattern. Annular dilatation leading to MR on left side, TR on right side. And if the papillary muscle, they get stretched up or they become ischemic. You can have a papillary muscle dysfunction. And when the heart cannot pump out blood to a large extent, what happens? It leads to collection of a blood into the heart, showing spontaneous echo contrast as well as increased incidence of mural thrombi. If you look at these points, they are self-explanatory. What does it means by? Now, here is a picture. This is my normal heart. In normal heart, this part, this apex is fixed, base is fixed. So this base mid segment starts dilating. When the mid segment starts dilating, the annular dilatation happens. The lot of blood goes back into the LA. So LA pressure start rising. Poor LV systolic function, and leading to poor LV systolic function, we have swelling of the blood in LV cavity. Normally, with every systolic contraction, the blood comes from LA, forms the vertices, and goes towards aorta. And this work we have been started recently doing in our lab, where we are studying the vertices of blood flow in our lab by a special hyperdoppler, and maybe coming out with some literature in next 6 months to 12 months. And when this vertices gets dearranged, so what exactly happens? The vertex which is forming towards the apex, they starts forming toward the bases and leading to poor outcome of blood flow in these LV diastolic systolic dysfunction. I'll come back. They're showing not a playing right now. Anyway, I'll show a couple of pictures from my armamentarium. Here's a person who has got LV which is dilated. And that's what I was saying. Put a cursor across this midline. If we find an M mode will have an increased E point septal separation. This annular dilatation will lead to significant torrential mitral regurgitations. And when this significant torrential mitral regurgitation is present, so the LA also starts dilating, leading to increased RV-RS systolic pressures. The most important parts come when you put a Doppler flow pattern across this mitral flow. You find tall E, very small a here. And as we have discussed in our previous lecture, tall E with small a with more than 2:1 ratio in a deranged LV systolic function is suggestive of raised LA pressure or raised L ref and diastolic pressures. LV is dilated, and once we saw these kind of a phenomena, I'll stop in between and go back and show you one dilated cardiomyopathy. And when you have this kind of phenomena, so what is, it could be ischemic, as I said earlier, again and again. Why I'm talking of these things is because if it's ischemic, we have all the word to revascularization them. In ischemic, you have a regional hypokinesis or akinesis. You may have a scarred tissue with the previous insult. Apart from echo, you can have an associative evaluation by CT scoring of a calcium. Then tissue Doppler imaging showed variable annular velocity. And the spectral imaging really helps you in showing a generalized or differentially reduced two-dimensional strain. If all these things are not contributory to your illness or diagnosis of your illness, the coronary angiogram really makes a lot of difference. In normal dilated cardiomyopathy or idiopathic, it'll be normal, whereas ischemic cardiomyopathy, it will be abnormal. So at this point, I would like to say we should not deny a benefit of getting an electronic coronary angiogram or cardiac CT or coronary CT in these subset of population who have got a dilated cardiomyopathies. Not at your level, but certainly I would like to spend a few minutes. That's the technology of today is we look at 4 chambers, 2 chamber and 3 chamber view, and we look at a 2-dimensional strain across all these segments. When we look at a 2-dimensional strain of all these segments, this is what is seen as totally red. If this is seen as abnormal, is reduced or the differential colors are seen in this particular spectrum pattern, we obviously start suspecting that patient possibly had an ischemic cardiomyopathy. Now here is animation of a two-dimensional stain. Let me spend a couple of minutes on this. We did talk of LV functions. We talked of diastolic functions. Request please everybody to silent their mics. Some of the mics are still open. This is what the acoustic markers is. This helps you in evaluating only this segmental stain of this basal inferior segment if it's a two-chamber view. And that's how it leads to development of how much this basal segment is thickening in this particular patients. And you look at very careful, these segments are contracting better than the segments which are on the lower side. That's what we studied with the longitudinal stains. Same thing we can study with the radial stains also. Dr. Amit, you are also causing a lot of problems. So this is how we have started studying these kind of abnormality in subset of populations, where we look at many other things. Then alcoholic cardiomyopathy, presentation is the same, but you have a history of alcoholism in this subset of populations. And very important phenomena which I'm trying to show over here is this patient who had a previous mitral intervention in form of mitral stenosis, though the mitral valve became normal, secondary effect is still persistent presence of a right-sided cardiomyopathy in a patient who had a previous mitral valve interventions. Why so? Many of you must be knowing about it, but just point it out. And today's circumstances for almost last 15 years, what we have been doing, if we look at the annulus of the mitral valve, is more than 40 millimeters in size. We always tackle the tricuspid, not mitral, tricuspid annulus is 40 millimeters or more in size. We always tackle the tricuspid annulus as well, along with mitral valve. And this patient only mitral valve was addressed to during her illness, not the tricuspid valve. This is an example of a dilated cardiomyopathy. You can see the LV is fully dilated. And with the treatment, it reversed over a period of time. And the most common example of all these people who are toxic or who have postpartum cardiomyopathy, and some of them who have got a Takotsubo kind of a disease of cardiomyopathy. There's one way to differentiate between ischemic and dilated cardiomyopathy by echocardiography is what we do, we give them a low dose dovitamin. If this low dose dovitamin helps in improving the contractility of the LV by more than 25%, low dose means less than 10 mics per kg body minute. And we start with the dose of 2.5 microgram per kg body minute. Every 3 minutes we'll increase the doses so that we are increasing the only force of cardiac contraction. We are talking of inotropic contraction, not a chronotropic contraction. So when we see this kind of phenomena, we really make sure that these people, they have possibly a viable myocardium, and that leads to further intervention of saving them from going further downhill. Couple of prognostic factors before. A couple of prognostic factors before we go further. How much LV is enlarged? How much the degree of LV dysfunction? What is the evidence of wall thickness? Involvement of RV and their functions, ventricular shape, presence of pulmonary artery hypertension, and the most important part is restrictive filling pattern or type 3 diastolic dysfunction. Look at this case. This patient has got definitely LV systolic dysfunction, but RV is vigorously contracting, and that's what really makes a difference. Then This patient has got a better prognosis as compared to a person whose RV is also failing. In management issue, this is not a topic of today's, but obviously we need to look at the decongestive therapy. In ischemic pathology, aspirin is a drug of choice. Follow-up is most important thing by echocardiography. If you suspect ischemic, dobutamine echo or CT cornea angiogram or cornea angiogram per se is the most important thing. And in cornea angiogram, if there is abnormality with the viability, we should subject them for intervention. This one very important modality is, which is known as non-compaction of LV. And this non-compaction of LV, if I've got a slide of that, I'd like to show that slide first before showing what is non-compaction of LV is. Yeah. Look at this short axis view, which has been published in British Medical Journal in 2014. How do you look? What do you mean by non-compaction? If you look at a heart segment, this is a segment which is compacted, and this is the part of a segment which is non-compacted. If I zoom up these segments, let me just explain you over here, then I'll go to practical aspects. If you look at this segment over here, this is a part of a compacted myocardium. This is a part of non-compacted myocardium. If the ratio is more than 2:1, means compaction is 1 and non-compaction is 2, we call them as non-compaction of LV. Now let's go back and see this particular phenomena in real time. What is in real time is, now look at this segment. This segment is non-compacted. This segment is compacted. But as you go apically, you find a lot of risces or tubercular material. That'll be more easily seen. Let me just go back. Yeah. Now see, this is compacted segment. And in this, you see, this is non-compacted segment. This is up to this point, this is compacted segment. From this point to this point is a non-compacted segment. The ratio of this compacted versus non-compacted segment, if it's 2:1, we call them as non-compaction of LV. This is a childhood abnormality. Does not develop secondarily. It's a childhood abnormality where in the absence of any coexisting illnesses, numerous excessively prominent tuberculations with deep intertubercular recesses. Intertubercular spaces directly filled by blood from a ventricular cavity on color flow mapping, and systolic ratio of non-compacted to compacted layers is more than 2:1. These two segments, these 2 points are very important. Now, look at this compacted versus non-compacted segment in apical segments. And on top of that, if you switch on a flow of blood, you can see this excessive recesses which are present in which the blood is flowing into them. And this is very characteristic of a non-compaction of LV. Why we spend time in this kind of abnormality is, this is a 3D echo taking a slice from a basal apical segment to basis. And you can see this non-compacted segments over here very categorically. So this is compacted segment is only this part. This is the part of a non-compacted segment. You can see it's much better in this particular segment. Here is a compacted segment. Here is a non-compacted segment. And why these things are important? Now I see this patient who has got a blood in the recesses and the cavities, and this is a non-compacted segment. And this is very categorically seen in 3-dimensional cycle. The compaction can involve both LV as well as RV also. Look at this non-compaction involving LV and RV. Why we spend a lot of time in this particular variety? The reason is, this is an independent variety of a dilated cardiomyopathy, which has got a very poor prognosis. This is lack of compaction of myocardium right from the childhood. And these people, majority of them who are primarily non-compassionate LV or RV, as per literature, do not cross the age of 25 to 30 years of the life. So I hope I'm able to say what is dilated cardiomyopathies. Let me move to the another variety of. So let's talk of the next variety of cardiomyopathy, which is restrictive cardiomyopathy. What is restrictive cardiomyopathy? Is a disease that affects the heart muscle. In restrictive cardiomyopathy, the heart vessels become rigid, unable to relax and fill with the blood. The function or squeeze of the heart may be normal, but the relaxation is abnormal. When the lower left chamber of the heart, the left ventricle is unable to stretch and fill with the blood, pressure builds up, causing abnormal heart rhythm and symptoms of heart failure. Now look over here. The most important part in normal versus restrictive cardiomyopathy is the LV becomes really, really stiff over a period of time and LA starts getting dilated. And they have a restrictive filling pattern along with this. And this pattern, if it is normal, it go to abnormal relaxation, pseudo-normal, and the restrictive filling patterns. It's the least common variety. Basic hemodynamic abnormality is the filling pressure, increased myocardial endocardial stiffness, impaired feeling, abnormally high filling pressures, pulmonary congestion, distension of central veins, hepatic distension, and finally the pedal edema. Varieties are primary is endomyocardial fibrosis, Loeffler's endocarditis, and again idiopathic. Secondary, where we have infiltration is, we have amyloidosis, psychosis, post-radiations, and storage diseases. Various storage like Fabry's and other, they also contribute to restrictive cardiomyopathy. And one of the most important part of this restrictive cardiomyopathy is even the atrial fibrillation patient presented with atrial fibrillation or what, they ultimately lands up in restrictive cardiomyopathy. What these patients they present with? Majority of these patients present with both biventricular failure, like LV failure as well as RV failure also. They present with biventricular failures. Failures of features of both congestive and hypertrophic. Hypertrophy due to infiltration of amyloidosis, glycogen storage disease, thalassemia, cardiac transplantation. We had one patient with pyopericardium presenting with presenting with restrictive cardiomyopathy. Atrial fibrillation is one variety. And the cardiac feature of these people, they have a normal size ventricle, preserved LV systolic function. They may have an increased wall thickness, could be a possibility because of a deposition disease. But the most important is biatrial overload, dilated LA and RA, dilated IVC with decreased inspiratory collapse. And here is a classical example of restrictive cardiomyopathy. Look at this picture. LV and RV, they are LV and RV, they are normal in size, but LA and RA, they are dilated. So normal size LV, RA, in presence of a dilated LA and RA, then normal LV and RV systolic function. And if you put a Doppler spectrum pattern across the mitral valve or a tricuspid valve, EA ratio would be more than 2:1 with a shorter deceleration time. And that's what tells you, look, these people have the restrictive fill-in patterns or restrictive cardiomyopathy. This is an example from a person who has got an abnormal fill-in pressures. So you can see both LA and RA, they are almost the same size. And what will happen? They have because of a discoordinated atrial and ventricular contraction, they have either a mitral regurgitation or tricuspid regurgitation as well. So Both the things would be present in this subset of populations, and they have a restrictive following pattern, and the tissue Doppler imaging will show up small E wave and there'll be no A wave. If you happen to see an A wave, that's not, it could be a restrictive following pattern. If you happen to see an A wave, this patient is not in atrial fibrillation. If you happen to see a lack of A wave, then patient is possibly atrial fibrillation. You look at their LA size or R volumes, they'll be increased in size. And we are not going to talk about this constriction versus restriction. This is a separate topic which you're going to dwell with over a period of time whenever we meet again for right-sided heart illnesses. Various pathologies in infiltrative cardiomyopathies leading to restriction is amyloidosis, iron overload for multiple transfusions, hemochromatosis, thalassemia, sarcoidosis, glycogen storage disease or Pompe's disease, or mucolipidosis. A few examples of looking at cardiac amyloidosis today is, I always say, whenever you see a picture where everything looks to be thickened and brightened, and when everything look at this picture, everything is thick and bright, as if they are reflecting by themselves. You look at the myocardium, you look at the endocardium, you look at the papillary muscle, you look at the valve, you look at the chamber, you look at the pericardium. And if you happen to see this kind of a picture, please think of amyloidosis as one of the possible diagnoses. And if you have a presence of associated pericardial effusion, it's a poor prognostic sign. They have a restrictive filling pattern, tall E, small A wave, sinus rhythm is preserved, and nothing to talk about these poor prognostic factors in, like, they have a thickened LV-RV, slower deceleration time. RV could be dilated as LV, Paris's pericardial effusion leads to a poor prognostic features in amyloidosis. I don't have many of the pictures of sarcoidosis with me, which is proven, but I would like to see at this point the diagnosis of sarcoidosis, like where you have a localized thickening and dilatation, usually at the bases. And when you have this kind of picture, this is a pictorial picture of a sarcoidosis. The basal segments are significantly thickened and they appears to be dilated. And if you happen to see this kind of picture in your clinical symptomatology in patients who are evaluating your LV, please think of a sarcoidosis as a first possible primary. And today's circumstances, sarcoidosis diagnosis is best done not by echo, it's done by cardiac MRI. Endomyocardial fibrosis is a very interesting phenomenon. What does it mean by? The apexes are obliterated to a large extent, deposition of the endomyocardium. This becomes fibrosed and they appears to be obliterated. And when these are obliterated, LV-LA size will remain normal, but you have the same features of a restrictive filling pattern of both LA and RA. And these features will lead to ultimately looking at the restrictive filling patterns. Arrhythmogenic right ventricular dysplasia is another very important thing is when you see a trabecular bands, excessive trabecular bands in the LV, RV apex. And when you have this excessive trabecular band in RV apexes, what do we mean by? They appears as excessive presence of the bands leading to a significant tricuspid regurgitation. But the most important diagnostic feature is despite almost normal RVRA size, the gradient is never ever more than 30 millimeters of mercury of a TR jet gradient. So an LV and RV and LV ratio is usually more than 2:1. And this is one picture of arrhythmogenic RV dysplasia. Let me go back and show you a couple of pictures for hypertrophic cardiomyopathies. All right. Let's move on to this hypertrophic cardiomyopathies. What is hypertrophic cardiomyopathies is a condition of heart muscles or disease in which muscles become thickened or hypertrophic. This thickening usually typically occurs in lower left chambers of the heart, which is known as left ventricle. Thickening of the heart muscle can occur in the septum that separates left and right ventricle of the heart, posterior wall and free wall, and the apex and throughout the entire ventricle. When the muscles become thickened, it may make difficult for an efficient amount of blood to flow into and out of the heart, especially during exercise. And in some cases, the thickening muscle can block the blood flow from left ventricular aorta, leading to heart obstructive outflow tract obstruction. So here's a pictorial diagram of the same thing. Here is a subject with the normal muscles. Here is a subject with significantly thickened muscles where septum is much more than the posterior wall. And during LV contraction, this septum obstructs the blood flow, may obstruct the blood flow during this LV contraction. It's a genetic disease occurring almost 1 in 500 individuals. Missense mutations of 1 out of 10 genes that encodes a protein in the cardiac sarcomeres, resulting in unexplained hypertrophy of the cardiac muscle, which is usually congenital, and predominantly septal with leading septal hypertrophy leading to dynamic LVOT obstructions. Here is a pictorial diagram or the photographic diagram of LV. Look at this septum, which is markedly thickened as compared to posterior wall. It could be obstructive versus non-obstructive, and the patient is presented could be an asymptomatic. And once we see these patients, the dyspnea, palpitations, angina, pre-syncope or syncope, they are very common film now. Yeah, in this subset of populations. What is the differential diagnosis? The most important part is of differential diagnosis to differentiate between hypertension or outlet obstructive syndromes. What are the outlet obstructive syndromes? Are aortic stenosis, coarctation of aorta. The same pictures can be seen in hemodialysis patients or CKDs. Even the athletes could have the same pictures. And all these things lead to a finally hypertrophy. And if they're not addressed to hypertrophy, they leads to dilatations. Okay. Now, this is a pictorial diagram or a static image of a patient of hypertrophic non-obstructive cardiomyopathy. Look at the septal thickness, look at the posterior wall thickness. And once we put an M-mode across this very precisely close to the tip of the mitral valve leaflet, interventricular septum is 3.07 centimeter and posterior wall is 4.28 centimeters. So it uniformly appears to be uniformly thickened. In fact, this thickness is little more, and this is almost like appears to be almost the same. And now look at this picture very carefully. When the LV is contracting, no part of this mitral valve is being sucked into LVOT. Now see very carefully. And whenever I teach, I always say, when you see an abnormal motion of the mitral valve, this is a normal motion. Mitral valve is opening 2 times. When you see the abnormal motion of the mitral valve, always think of obstructive cardiomyopathy. Now look, concentrate like Arjun's eye is, it's only in 2 times with every diastole. And if you put in a colors, there is no evidence of turbulence in this patient with LVOT obstruction, without LVOT obstructions. Tell me what to do with these people who are not listening at all. I think I need your comment on this chat box. I need a definitely comment from your chat box, but many people, they're not still listening and they do not understand. I do not understand why they're not listening. Can't they keep their mics silent at all? And this looks really bad, you know. First of all, they are not listening, and second, they are disturbing everybody who is trying to listen. Another example is look at this contraction. We do not see any obstruction lesion out here. You put a Doppler flow pattern, and the most important part is once we see these people, we do not see any systolic anti-emotion in the mitral valve leaflet. Look, this is systole. This is diastole. We do not see any advancement or systolic anti-emotion of the mitral valve leaflet in this subset of population. This is one very good example where the patient bases are free, but the apex is significantly hypertrophic. This is one variety of hypertrophic non-obstructive cardiomyopathy, and this is three-dimensional picture of the same thing. Look, very classically now you can appreciate the apical hypertrophy where bases are reasonably normal, but apex is significantly hypertrophic. And not at your level. We used to see them a lot by whenever we had doubt, we go to 9 segment model. We see apical hypertrophy, but bases are spared to large extent. Now you can see the bases in cut sections are normal, but apex is significantly hypertrophic. This is very another variety of a thickened sigmoid septum. You must have seen like many people presenting with thick. This is of no value except for the fact it can produce turbulence across LVOT, and on top of that turbulence, it can also give rise, if the heart tachycardia is present, it can give us some dynamic LVOT obstructions. Then one factor is like what is how to differentiate between aesthetic heart versus hypertrophied heart is we have a normal LV wall thickness less than 14 millimeters. Genetic testing is negative, family history is not there. Pulsive Doppler study mitral valve is normal. E prime is more than 7 centimeters. A large LV cavity appears, but it regresses over a period of 4 to 6 weeks if you have a deconditioning. But the characteristic feature of hypertrophic cardiomyopathies are asymmetrical septal hypertrophy, systolic anti-motion of the mitral valve leaflets in M mode and 2D, and then dynamic LVOT obstruction along with mitral regurgitation. Now, look at this picture, which is very characteristic of hypertrophic cardiomyopathy. Concentrate on this. I'm keeping my sample volume or a cut line at the mitral valve tips. So this is systole and this is diastole. Look at my hand downstairs. This is diastole. With diastole, the mitral valve opens and closes. So this is diastole. Mitral valve opens and closes. This is diastole. This is diastole. This is diastole. This is diastole. But in between two diastoles, you see the anterior mitral valve leaflet is going up. This is systolic anti-motion of the mitral valve leaflet. In comparison, look at the picture over here. This is SAM. Here, it is during systole, the systolic anti-motion is touching the interventricular septum. And these kinds of pictures, once you see in clinical or M mode examination, it really gives you help you in a lot of factors talking about systolic anti-emotion. Now the question comes when the AML is being sucked into LVOT, so the mitral valve will remain open. So you'll find a torrential mitral regurgitation during systole or mid-systole. Here is mid-systole, where the mitral valve remains open. And this mitral valve is closed during early systole. Look, this very characteristic image. Now concentrate on this M mode, this mitral valve. I said something is happening on the mitral valve. This is not an abnormal function of the mitral valve. Normal opening of the mitral valve is not more there. Why the normal opening is not there? Look at this. This is being sucked into LVOT during systole. Let me try to freeze this picture. With every systolic contraction is being sucked into LVOT, and because of this, it leads to a dynamic LVOT obstruction. What do you mean by dynamic? During contraction, it leads to an obstruction with inverted key slope shape pattern of the aortic flow. And look at the gradient is almost 210 millimeters of a gradient across LVO. And the Doppler flow pattern is in aortic stenosis, there will be shorter acceleration time, long deceleration time. Here, there's a long acceleration time and slower deceleration time, which is known as SAM or systolic anti-emotional Doppler lift. This is what I was trying to say. In aortic flow, shorter acceleration time with a long deceleration time. Here's a long acceleration time with shorter deceleration time, which is dynamic LVOT obstructions. All right. So let's go further and look at this patient. Once you have a dynamic LVOT obstruction when mitral is sucked, you have a significant turbulence at LVOT along with significant mitral regurgitations. So if you have a significant obstruction LVOT and a dynamic LVOT obstruction, if you can't find MR, you have to be very, very sure that you're looking at the correct picture or not. Features, as I said earlier, asymmetrical septal hypertrophy, small LV cavity, systolic anti-motion of the mitral valve leaflet, then dynamic LVOT obstruction more than 25 millimeters of mercury in resting phase and more than 30 in exercise phase, and missed systolic mitral ligation are characteristic features. And in case where you suspect hypertrophic cardiomyopathy, but you can't demonstrate them, do a Valsalva maneuver, give them a sorbitrate, or look at this particular feature in post-extrasystolic beats. What we do in our lab is we ask them to have a Valsalva maneuver. And a very simple way of doing a Valsalva is ask them to hold their breath and gradually they go into Valsalva automatically. Usually presentation is a younger age, definite family history is present, and they don't present with the hypertrophic features, they present majority of time with syncoping. I'm not going to details of this hypertrophic cardiomyopathy management is, but once you have an hypertrophic cardiomyopathy, you need to have an intervention definitely in this subset of population of hypertrophic cardiomyopathy in the form of septal ablation or AICT or both of them. A couple of prognostic features, which I'm not going to talk about at your level of these prognostic features of septal hypertrophic cardiomyopathies. Another variety is where the obstruction is not at the level of LVOT, the obstruction is at the level of mid cavity of hypertrophic cardiomyopathies. Then I showed you an apical hypertrophy already. Then another variety is when not the AML which is being sucked into LVOT. In fact, the cord, which is long cord, is being sucked into LVOT during every systolic contraction, which is known as caudal SAM. So with this, I would like to stop it over here and take your views, whatever you want to, your questions, and